Good morning, everyone. Hope everyone is doing well. My name is Dr. Aziz Seixas. I am the interim chair for the Department of Informatics and Health Data Science. And I also lead the Media and Innovation Lab here at the University of Miami Miller School of Medicine. So to our U family, welcome, and to our non-U family, meaning folks who aren't with us here in I would hope I would say sunny Miami, but it's overcast today. But it's always sunny in our hearts here, and that's the spirit of Miami. Again, welcome again to another installment of our webinar series where we're going to be focusing on the future of health data innovation. And like always, we have another amazing speaker, Dr. Kurt Rohloff from Duality, who is going to be talking to you all about something that I literally have been geeking out on for the last year. We had submitted a massive grant last year to the NIH, trying to put together all these massive types of data. And one of the main concerns was around security and how do you harmonize and stitch data together. And I promise you, that Dr. Kurt Rohloff is one of the most seminal speakers and thinkers in this space, and you are in for a treat. But we could not have done this without our incredibly talented faculty and staff, to whom I pass the baton now to Dr. Mairead Maloney, who is just an amazing new recruit for us and doing incredible work. So again, we'll have this monthly. Welcome again to the U and the Department of Informatics and Health Data Science. I hand it off to you, Dr. Maloney.
Thank you, Dr. Seixas. That was a really kind introduction. And we are indeed so thrilled and so excited to have Dr. Rohloff here with us today. Just a little brief intro. He is the co-founder and CTO of Duality Technologies. He's a multi-project DARPA principal investigator, and he won the Director's Fellowship Award. He is co-founder of the open source OpenFHE Homomorphic Encryption software library that enables practical and usable privacy and collaborative data analysis, very relevant to today's talk, of course. He also generates, develops, and commercializes innovative secure computing technologies with a focus on privacy and AI and machine learning at scale. He has repeatedly led successful multi-million-dollar, multi-year, multi-performing teams, transitioning and applying multiple first-in-the-world new technology capabilities for both the DoD and commercial use. We are so excited to have you here today, Dr. Rohloff, and I will let you take it away with your talk.
Great. Aziz, Mairead, thank you very much. I love the introduction. I also need to add, I'm actually a former happy resident of South Florida. I spent actually quite a bit of time in Plantation. I am missing it right now because I am up here in New York City and it was negative 15 Celsius when I woke up. So looking forward to the palm trees and kind of everything else that South Florida entails, kind of whenever possible. But yeah, no, thank you very much for the introduction. I'm keeping up kind of an open eye on the chat as you kind of go through too. As you kind of came through my intro, my background in terms of just where I started my career, I'm a PhD, not an MD. You know, the other kind of doctor, kind of for what it is. And I started in U.S. defense industry, and particularly an organization called DARPA, the kind of the blue sky wing of R&D around secure data enabling secure data collaboration. So I'm used to giving briefings where I'm interrupted early and often, and I would greatly appreciate engagement, questions, anything else that kind of comes up as we go, and I'm happy to kind of go forward from there. So let me start by sharing my screen, and we'll dive into it. So, as was kind of given in the introduction, what I focus on, what I'm trying to enable through my research, my open source library, through the company Duality, is enabling secure collaboration on very sensitive data. And that's writ large about how organizations can basically take sensitive data, things like financial records, things like medical information, things like sensitive demographic information from census, and collaborate and get value from that data without risking the privacy of individuals, the privacy of companies, while respecting regulation and of course respecting the rule of law. And so, I'm very proud of this work that we were doing for DoD and DARPA. I had kind of a bit of a drink the Kool-Aid kind of moment where I think I could start a company around this. And so basically I've done that. And, this is talk I'm going to be giving today is a bit multifaceted. It is a bit about, what's the underlying innovation in secure collaboration for data collaboration in IT. It's also a bit of case study about how we've been deploying it overall, both in terms of using open source software, and I'll get to that, but also how you do it, potentially with real world application and kind of taking basic research from the proverbial lab into real world deployment. And so I'm not doing this myself. Everything's a team, and as it should be. I have five co-founders, myself and two MIT professors, Shafi Goldwasser, Vinod Vaikunthanathan, and my other partners, Alon Kaufman and Rena Shansky. We've been on this journey together for a good 7-8 years. And although we started more in the national security space, Homeland Security, fighting money laundering, counter-terror financing, things like that, the past few years, we've been focused very heavily on medical applications of this. And we've had some really nice partnerships with Dana-Farber, some nice sponsorship from NIH and CDC. And we're currently executing on a set of activities for ARPA-H, the new ARPA focused on health, about how we could build secure data collaboration. And I think I saw Matt Curry in the audience, who was one of my colleague collaborators on some of these activities also. So thank you for joining, Matt. So, and as we're kind of going through this, what I'm going to try to do is drive a few discussions around case studies overall, but kind of also try to get at the so to speak, the so what under the covers, and what are the kind of design patterns that one should try to take away for secure data collaboration, and what it means, and why that really matters for medical collaboration in general. And the underlying part of it is that data inherently is highly fragmented. You think about this is kind of like a canonical example that we talk about with the NIH often, is the rare disease problem. And I'm sorry, like I said, I'm a PhD, not an MD, so I'm going to get this approximately wrong, but please bear with me. A rare disease is a disease that affects a very small portion of the population. I'm sure someone correct me on this, but let's, for the sake of discussion, let's say 1 in 100,000 people. And so any one clinician might see at most any one example of a rare disease over their entire career. And it makes it very hard for pharma, for medical researchers, for other kinds of interested parties to aggregate data and then start to develop, insights that might eventually lead to better positive clinical outcomes overall. And one of the challenges with this is that up to now, a lot of data collaboration, especially secure data collaboration, has very, very much been an all or nothing kind of proposition, where my colleagues in Dana-Farber, for example, if they need to go and collect data from clinicians across Massachusetts, basically what they need to do is they need to sign data use agreements, MOUs, other kinds of legal instruments that basically either through civil or criminal civil or criminal legal ramifications bind them to respect the rule of law and privacy and whatnot as it relates to kind of this kind of activity. The challenge with that is that it's expensive and it's slow, and it slows the pace of innovation in science. There's also the challenges associated with how these legal use agreements, because they are so expensive because of the lawyers, the top tier research organizations like University of Miami, Dana-Farber, Harvard Med School, Broad Institute, they have a large allotment of lawyers that can do these things for a cost, for a cut of grant funding and things like that. But the challenge is that, organizations at the second tier, third tier, or even citizen scientists don't have access to these resources. And so it limits the pool of researchers that can operate on this kind of data. And so one of the kind of the missions that we have at Duality and or broadly is how can we break down these silos of data? How can we make it easier for researchers to collaborate and access sensitive medical information to increase the pace of science, increase the velocity of science? How can we make grant making, money from NIH, taxpayer money, more effective so that more money goes to real research as opposed to the kind of the legal strictures of signing data use agreements and things like that. And so what we've been doing is we've been developing these piles of technologies called privacy enhanced technologies that enable data science on sensitive data, that protects confidentiality, that respects regulation, and enables collaboration overall. And it's been a bit of a wild time to kind of work with these privacy technologies lately. And one thing that's been really nice up until 2 days ago is that the up to recent head of OSTP, the Office of Science Technology Policy, basically the main science policy shop in the White House, has been putting out some very, very strongly worded and very nice policy positions about secure AI and the viability of privacy technologies as a means to adequately protect data for secure data collaboration. And this was all driven by Dr. Arthi Prabhakar, the former DARPA director and one of my former sponsors, who's been driving this out of OSTP. Some of that's changed with the new administration. We're kind of seeing where that might actually land with respect to privacy technologies. But the US government has made some very bold statements around this. And we see this not necessarily as science in and of itself, as it is an enabler for science and how one can use data collaboration to enable higher quality, faster science as it is. And ideally, like I said, with the social good coming out with better clinical outcomes and things like that. So, and it's not just the US, even like UK, like ICO, Information Commissioner's Office, which is the main privacy regulation branch of the UK government, has also made some very similar strong statements in concert with the US government. And there's a number of ongoing collaborations funded by NCI, National Cancer Institute, and DCIT, which is kind of like the UK equivalent of NSF, to enable secure data collaboration, particularly in furtherance of rare pediatric cancer research as it is. And we're engaged with some of that with the UK government, and happy to go into it too. But, to kind of tie it back to the nuts and bolts of healthcare, it comes to how one enables and protects privacy, protects security, and breaks down data silos while also protecting, intellectual property and other kinds of data. And really to kind of beat the drum, it's how do we basically enable easier sharing of data? And I want to be very, very careful about this. It's not like we are doing anything untoward. It's how do we protect legal obligations and respect legal obligations while also making the legal obligations less hindering to science being done. So there's a few different kinds of collaborations that I would love to kind of talk about and use as a case studies where we're going. And probably our most public one has been a collaboration where we've enabled Dana-Farber Cancer Institute, DFCI, to collaborate with Mass General, MGH, to share and collaborate on cancer imagery data. And we're using different kinds of privacy technologies to do that. In this case, we're using a set of technologies called secure federated learning. And it's basically how one can share these really complex, really large imagery data to build better models and train classifiers for certain kinds of cancers. I also alluded to a use case that we have where we're enabling what's called cross-border data collaboration. We're starting with a UK-US initiative funded by NCI, basically for rare pediatric cancers, and I'll be talking about that a little bit as a case study. And we also a pile of work we're doing right now for ARPA-H. We're funded by ARPA-H, particularly to build an open architecture. And this is the kind of thing where there's some folks at University of Miami who was interested in this. We'd be more than happy to kind of find a way to collaborate about how we can create an open architecture so that less well-resourced, less capable data sources could basically securely share data with the major health research centers. Case in point, and one of the motivations for this is, for example, some of the work that ASU does, Arizona State University. Arizona State University is basically kind of like the main medical research center, one of the main medical research centers for the state of Arizona. And one of the challenges that is prevalent in the desert Southwest is that they have these very low resourced rural and tribal health centers that are historically disadvantaged and are usually skeptical of sharing data with ASU, with other parts of the government, even the federal government. And so how can we provide tools that enable secure data collaboration with very, very strong guarantees on the tribal and rural health centers maintaining degrees of tribal sovereignty also, and still enabling basically these low resource environments, not necessarily to operate as a peer of a large research organization like ASU, but as basically a way to feed data into it. And I'm going to be talking about that a little bit too, and how that is potentially repeatable, and how we're talking with other research organizations to deploy this as a set of open technologies as it is. And this is something that's very important to us, is openness. And we have a set of publications and the proceedings in the National Academy where you can do things like genome-wide association studies on encrypted data too. So, so to kind of dig into it a little bit, we see kind of different ways that data needs to be collaborated on, and different kinds of design patterns that go for that. And one that we see very, very commonly is this, so to speak, remote data analysis. And this, for example, is where a medical center that might not have a large data center associated with it could go and store its data on a commercial cloud environment, and then run computations on that data on the cloud environment also. And one of the things that we're doing is we're actually enabling the encryption of the data at the medical center, move that encrypted data off to the commercial cloud, and then run computations and analytics on that data while it is still encrypted. And that's a kind of a big thing, because up to now, a lot of commercial clouds have been hindered in terms of the use of this data, other than very expensive secure enclaves and things like that, enabling computation and encryption, what you call encryption in use. The other is remote design pattern is this approach called remote federated data analytics. And this kind of approach is where you have a number of peer organizations. Like I said before, you have, for example, Dana-Farber, you have Mass General, they have a bunch of imagery data and they want to collaborate. How do they, as peer organizations, run this collaboration without necessarily revealing privacy sensitive information to each other? And there's a set of design patterns around multi-center studies type activities built around federated learning that does this kind of stuff. And then we have this remote linking type information. And this gets at some of the work we were doing with genome-wide association studies, where you might have one organization, say like the Broad Institute, has a pile of sequenced genomic information about a set of patients. And they have another organization, say like again, Dana-Farber, that might have a pile of information about medical records of an individual. And so how do you basically enable collaboration on this data, basically link the data, and then run studies looking at, for example, things like correlation analysis about what kinds of mutations are indicative of certain kinds of symptoms, as it is. And so this is a thing that we've been pushing out also, and have a number of publications on, and kind of like the joint analysis of patients as it is in virtual join type operations. So happy to kind of talk overall about high level privacy technologies, but I do want to kind of pause for a second in case there's any quick questions. And like I said, I do want to induce anyone to kind of put things in on the chat, which I do have open on the side if anyone does have any questions too. And I'll have time at the end also, of course. So, getting into it, and I know this is a little bit of an eye chart, but there are a few different privacy technologies overall that we have been using, and maybe what I should do is kind of focus on these top three as they are. Oh, excuse me. And we have been applying these different kinds of technologies, like secure what they call trusted execution environments. So these are, for example, special chips that you can get from Intel, like Intel Corporation, AMD, even NVIDIA has them now, where they have basically a chip, and they have a little bit of core and memory off on the side that's secured, where we can run secure computations in here. And it is not necessarily rolled out into kind of the broader society quite yet, but it does provide a nice pile of ways of basically moving data into what is basically a secure environment, and running computation in this special part of the chip overall. There's a lot of IT challenges about how you run collaboration across multiple of these environments, and we're looking at that. And then there's this, so to speak, the secure multi-party that allows kind of a peer-to-peer, things like federated learning. And the core that we like to focus on is the capability off here on the right, which is a framework called homomorphic encryption. And what that basically means, and I'll give a few examples of that, is where you can take data, compute, and then encrypt the data and compute on the data while it's encrypted also too. Sorry, I just saw a quick question from Jim Berlin, who, apologies for missing this earlier. Do you exclude commercial pharma biz? Basically, what we do is we do engage with folks who basically get value from data collaboration also. So no, we do not necessarily exclude commercial pharma biz as it is. Most of our case studies and examples here that I'm going to be talking about are focused more on medical research centers and things like that. But we have had some pharma engagements too, and always happy to talk about that offline if it's of interest too. But thank you for asking, Jim. Okay, so moving on a bit, I'm just going to skip over this. So, to kind of work out an example of this privacy enhanced real world data analytics as it is, and the high level goal is that you have these multiple organizations that are data sources. And these, for examples, could be clinician sites. It could be, for example, tribal and rural health centers. And they all have data that are relevant to a computation. And the challenge is basically, how do you link that data together and get some sort of insight result? And we have a set of frameworks that basically allow each of these data sources to encrypt their data locally with their own encryption key, and basically result in something called ciphertext, or what's called encrypted data. And once data is encrypted, it's very secure. It allows data to basically be uploaded to a medical research center, and then basically we have open source tech, that allows that data to be linked together and then be computed on and obtain a result. And one of the nice things about what our framework that we're doing with this is that the encrypted result can only be decrypted if all of the data sources agree to approve the decryption. And so this avoids things like that we call in the field the Henrietta Lacks problem, where someone contributes data, and once you contribute data to someone, you have no control of it over anymore. What we can now provide is the way to basically perform secure analytics on data, respecting privacy, but still allow data sources to control the use of that data downstream as a way. And we've been looking at how, for example, clinician sites, tribal centers, for example, can start to be compensated for their data collaboration also, as a way of kind of enabling and inducing basic collaboration for these kinds of activities overall. So Ishwar had a really, really good question. And Ishwar is asking, would encrypting the data obviate the need to obtain patient consent or otherwise have an IRB approved waiver? The short answer is no. There is no excuse for patient consent overall. I'm not aware of any kind of data sovereignty regime, which is basically a fancy way of saying a government organization that has so far approved the removal of patient consent. But it greatly reduces greatly lowers the IRB bar overall, and that because the data is basically being secured, and because researchers only have access potentially to the results of data, it generally makes IRB approvals easier, is what we've seen in practice. And it kind of gets to what I was saying before. One of our goals is not to sidestep privacy regulations. Our goal is to minimize the friction caused by our privacy regulations while still respecting privacy also. But thank you. That's an excellent question, and thank you very much. And so we're basically running computations on this data, as I said, and examples of this are descriptive statistics, Kaplan-Meier survival analytics, building regression models, correlate analysis, statistical analyses, generalized association studies, and more, kind of for what it is. And this is, like I said, all been peer reviewed, proceedings of the National Academy, and so forth. And initially, this work was kind of the core cryptography work came out of work my team was doing for the DoD and DARPA, although a lot of the kind of add-on application to the medical domain was funded very heavily by NIH and particularly NHGRI, the National Human Genome Research Institute, too. So we like to think we have a little bit of legacy to it. And the other underlying cryptographic primitives, the underlying privacy primitives, just to kind of hand wave through what's actually going on, is that you might have a data source, a data client, and it could be something as small as a mobile device, like a phone. The FHE client has data. Could be imagery, could be data collected on a phone, could just be a pile of VCF files, particularly if you're into GWAS and gen-wide association studies and things like that. And what we can do is that we have a computation host where we want to run computation. You can take a public encryption key, send the public encryption key to the data source. The data source can encrypt that data, send only the encrypted data to the computation host, and then the computation host, without decrypting the data, without having access to any kind of decryption key, can run computations on that data while the data is encrypted, get back an encrypted result, send the encrypted result back to the FHE client. FHE client can then use their secret key or decryption key to generate a decrypted result. And the black magic behind this is that if you can run the same computation on the source data without encryption, and you'll get the exact same decrypted result. And so there's a bit of a parlor trick that we've been doing for some time with proof of concept with medical research organizations, where they can run a study in the clear without protections, and we can drop in and do the exact same thing with protections and get the exact same result to 3, 4, 5, 6, 7 digits of precision overall. And so that you can provide very strong guarantees, both experimentally and theoretically, about the same results also, and with very high degrees of accuracy. And the challenge with this also, though, is that there's no free lunch. One of the challenges is an issue of performance in terms of runtime. And sometimes, the way we look at it overall is that if you have access to data and a lawyer might take days, weeks, months to hammer out a data use agreement, what we can do is that we can take a computation like a linear regression and run it in the order of seconds as opposed to milliseconds. And so, what you're doing is you're taking a human loop process that might take hours or days and replacing it with a process that might take seconds. And so that is where the big win is for us, is taking a human-driven process and making it increasingly automated and more secure at the same time. And so I'd be remiss if I didn't talk a little bit about the underlying open source library that we have. It's called OpenFHE, and FHE stands for Fully Homomorphic Encryption. Particularly coming out of the DoD, I do need to be very careful to say it's fully export compliant. Other than a few of the kind of the 5 kind of naughty list countries that we need to be careful about. It is export compliant. It also has something called quantum secure, which of course matters more for national security applications than for medical. What that basically means is that nation state adversaries that do or could soon have quantum computing devices can't crack this cryptography, which is a nice thing, particularly if you're dealing with things like financial records, counter financing applications and things like that. But it's a nice to have. And so we had a broad community of contributors to this open source library. NIH has funded work, CDC has funded work, DoD has been very heavily, a pile of the brand name corporate organizations like Intel, Samsung, Amazon, AWS are engaged, in addition to the usual suspect IT universities like MIT, UCSD, and so forth. It's malleable, and we basically have set it up to basically make it as easy as possible to deploy to. In case there's any questions, happy to take them as we go. So we've run a case study of this work, and this is a high-level overview of the case study that was recently published, and happy to kind of share literature on it too. We built up a partnership with Tel Aviv Medical Center, TLVMC. And basically, if you're not familiar with it, it's basically one or the top healthcare research organizations in Israel, basically to see how we could apply data analytics for real-world evidence while respecting private health information, PHI, overall. And basically, the high-level challenge is to show that this is a bit of a proof in the pudding. Show it could actually work as it is. And high level is that it did. Bottom line up front, and it was published in Proceedings of the American Society of Clinical Oncology. Also, we have also a higher level paper that would also been put out too, as it is. The high level use case was basically looking at how the effects of certain kind of pharmacological interventions associated with colorectal cancer patient survival overall. So we have a relatively small, in the scale of nation state, but non-trivial data set of 623 patients, 24 variables, and roughly 15,000 data items over this data set. And we wanted to basically examine the survival effects of a certain kind of treatment with and without cannabis. Basically, if patients are consuming cannabis, what's the effect of survival when they're also getting this other kinds of treatment? And I apologize, as I said, I'm a PhD, not an MD, and I've never been able to pronounce that word properly, or so I've been told, so I'm not going to try. And basically, the high level outcome of it is to perform a statistical analysis of basically with Kaplan-Meier and log rank tests overall, and basically to see if the results of the analysis done in the clear matches the results of the analysis done in encrypted also. So this is a little bit of a kind of a proof in the pudding type activity overall. And so we did a few different kinds of analysis, all fairly standard stuff, looking at things like mean, median, standard deviation for cancer onset, frequency analysis for gender, chi-squared analytics and t-tests and so forth overall. So, like I said, kind of a very bread and butter approach to data analysis as it is. And what we basically found is that by running the study, that basically all accuracy metrics were found to be within 7 decimal digits of accuracy. So pretty good for science, in our opinion, to basically be able to tell that you have a process and you can run encrypted with very, very high degree of accuracy as it is. And overall, basically showing the medical results, basically the effects of survival with and without cannabis overall. And it looks like, and actually in this case, like I said, I leave the interpretation to the medical researchers. Cannabis was led to better survival outcomes overall with cannabis. But like I said, the real impact for this is as much in the kinds of efficiency and overall gain of efficiency as it is. Basically, in the Israeli context, in the Israeli kind of data sovereignty regime, there was a much lower burden for data use agreements with this technique overall. And also lower legal liability. And we did this study basically before OSTP started making these statements about the acceptable use of privacy technologies. And we were, for the study of 600 patients, running these various kinds of survival analyses overall, computation took on the order of minutes. What we did find out, though, in working with the study authors and our collaborators at Tel Aviv Medical Center, was that they were to do this exact same operation with the exact same data, basically because of IRB and internal processes and things like that, took them 10 hours of effort overall that was cut out by using the privacy technologies as they are. And so this, as far as we're concerned, is a big win. And it kind of gets to the punchline I was talking about before, of using privacy technologies to respect privacy, but also make science more efficient too, as it is. So that's a big thing for us overall. And we had other studies that we were also running associated with this, particularly immunotherapy for renal cell carcinoma. And we basically got similar results the second time around, to run various kinds of computations with different kinds of cryptographic configurations to get relatively small error terms also in terms of the difference between computing in the clear versus computing encrypted also. So again, very nice results. And like I said, I won't necessarily read the results to you, but happy to kind of reference the published studies too, as they are. And so this basically is enabling a set of capabilities where it allows multiple institutions, and particularly disjoint clinical and genomic data, to perform these kind of joint analyses for things like survival analyses and log rank analyses and other kinds of, like I said, bread and butter stuff. And so we can basically enrich data, join data, and start to kind of do these more comprehensive analyses too. And like I said, do these various kinds of results as they are, and like I said, deep dive into accurate things too. And punchline is, pretty accurate. So and that was, like I said, just one of the approaches that we've been taking. There is this other approach, and this is basically how we can do federated learning. So not just running basic statistical analysis, but how we can even start kind of going a step beyond, really good hardcore statistics into things like machine learning. And the use case for this is how can medical research centers collaborate on imagery data to build better classifiers for different kinds of cancers overall. And we've been kind of using other privacy tech for this, like the trusted execution environments, like the federated learning as it is, and aggregating data to kind of run these studies also. And the underlying for this is basically leveraging these down in the weeds, little chip components called trusted execution environments that are prevalent on AWS and GCP and Azure and kind of the various commercial cloud. Up to now, these technologies have really been more used for consumer grade electronics. Things like testing ownership of digital content, like movies and stuff like that. And what we've been trying to do, what we have been doing, is taking these technologies and kind of deploying them enterprise grade for large scale analytics. And this is kind of gets at the kind of the hardcore IT part of it, is that a lot of these kinds of trust execution environments on things like Intel SGX and things like that, they're very memory bound. They're very kinds of relatively low resource that don't lend itself to very large enterprise scale computations. And we've been pushing this forward as part of these overall machine learning capabilities too. Seeing basically how we could do this as part of this federated learning capability. And so what we've been doing is a bit of a mix and match. And this is where I see kind of the future of privacy tech going, particularly for medical analytics, is, we have homomorphic encryption, which I laid out before, which is really, really highly secure, really good, but it has, in some sense, these potential performance implications for very heavy computations like machine learning. And on the other extreme, we have these consumer-grade trusted execution environments, which are very good, but don't necessarily scale because of memory limitations. And so where we're going as a community is, kind of like, talking about how we combine chocolate and cake. Two very good things, put them together, you have something even better. And how we can take these things like fully homomorphic encryption and these things like trusted execution environments and stitch them together for a more comprehensive, highly performant set of capabilities that enable very broad enterprise scale hard computations, like machine learning on very sensitive data. And so this is where we're going right now with our partnership with Mass General and Dana-Farber, and rolling this forward into medical imaging support as it is on things like a citywide scale, like the city of medical research centers in the city of Boston, for example. Going forward from there. So, as I said, there's a few things that we've been looking at overall for doing things like, pathology images and training things like SVMs, support vector machines, using cancer classification models as it is an exemplary use case for this. And the overall topology that we've been basically deploying is how can basically medical centers share their data while respecting privacy also, using these kinds of medical frameworks. And although this is the diagram, I just have basically what you call a two-party interaction. It does scale also for other kinds of capabilities overall, and doing things like supporting decentralization of data and enabling a high-level flow of these kinds of linking and collaboration of data overall, and more access to data as it is. And to kind of pull it back to a slightly higher level, where we really want to go with this is this notion of enriching and analyzing data in a privacy protected way. And this is basically where the community is going in duality in particular, about how we do things like join, link, and enrich data. Basically, in a kind of the vision that we have and that we're trying to basically roll out is, we don't want the clinicians, we don't want the medical researchers to have to get trained up on another tool. If they're used to using things like Jupyter Notebook, if they're used to using things like R, our goal is, and what we're doing as a company, is providing these capabilities as a backend to Jupyter Network, Jupyter Notebook, as a backend to R. My experience basically rolling out tech for military is, if you have to kind of train, folks with boots on the ground, retrain folks with boots on the ground to use a new tool, they're not going to use it. And we have kind of a similar attitude about deploying these things in medical environments and whatnot. Is we don't want clinicians, we don't want medical researchers to have to get trained up on a new user interface. We want to basically use the same front ends and swap out the back end. And this also then gets a bit to, our overall vision for how we basically make privacy technologies real for the health enterprise. Is it's a stack. It's a stack of solutions. The underlying privacy tech is an underlying set of capabilities. Very firmly, we believe it needs to be open and open source or commercial off the shelf. But on top of that, you need a stack of modular, kind of wrappers of things that enable encrypted queries, machine learning, and then a higher level set of frameworks for user interface, data management, governance control, reporting, and enabling auditing, so that it fits seamlessly into the existing workflows of the medical enterprise. And this is, I'll put my hat as an entrepreneur. This is where academic research or open source technologies, where the rubber meets the road with actual real enterprise capability, is in the engagement of existing legacy IT enterprise. So you can support, the normal practices associated with data governance, user access control, collaboration management, and all these other kinds of things that basically make IRB approval much easier, for example, as it is. And so, I can go down in the weeds on that if you want to, but a large aspect of taking IT research out into real world is basically hanging on all the bits and pieces that make it easy to integrate with existing enterprise too, as it is. And then tie it back to where we see the sponsorship going. We do see the need to kind of align with where the wind blows, so to speak. Things like the DMI vision, the Digital Modernization Initiative vision, of basically breaking down silos, make it easy to kind of stitch together health data systems while also protecting privacy. And of course, engenders all these other kinds of follow-on questions too. Whether it's things like, how can you comply with existing state and national privacy laws to respect data sovereignty? How can you basically enable large surveys? How can you tap into data that already exists and reuse data exist where consent might have already been given? And I've talked with a number of colleagues in the medical field who have told me basically, consent might be granted for certain data sets, but effectively is treated one-time use only. And so how do you basically unlock and reuse data for multiple studies is a big part, in addition to kind of the bread and butter of EHR engagement too. So I know I'm getting a little bit close to time. I know it kind of ran through a lot of things, but first off, thank you very much for your attention. One of the nice things about having a relatively unusual name, Kurt Rohloff, is that I'm relatively easy to find online. And so I'm happy to take any and all questions. I'm also more than happy to take any and all kind of follow-up kind of as it is too. And the folks of you, Myri and Azizi, thank you very much for giving me this forum. I'm always happy to kind of share what we got going on as it is. So thank you.
Go
Thank you.
ahead, Mairead, please.
I learned so much, and this is so relevant to what we're doing. It's really exciting, and we so appreciate your time, your expertise. I would love to open it up to the floor to see if there are questions. So folks that have questions, if
If
you
there
raise your
aren't any questions, Mairead, I have questions.
I know you do, but I also saw that LaRonda was unmuted. I didn't know if she had a question. And
Oh,
folks
even
in
better.
yeah, if folks would like to talk instead of type into the chat, let me know, raise your hand, and I can allow you to talk.
I know you mentioned about the Henrietta Lacks like problem, and it's regarding to before, because technically before that, not a real study. Um, there was no permission involved back in the 1950s
Yeah.
regarding patients. So this you've seen afterwards, like recently after the family decided now for new data, they need permission, I believe. So how does that integrate into this new data encryption?
Right, right. Yeah, you're right. Tongue in cheek, the so to speak labeling of this as a Henrietta Lacks problem is not accurate and probably not fair actually to the gravity of that situation, kind of for what it was also. The heart of it, what I was trying to communicate, and thank you for calling me out on this, is more driven by once data is shared, how do you make sure that it is being used in a way that respects the wishes of the legal data steward, the kind of the folks with legal rights about control of the data also. And the situation I like to kind of point to is more relevant to things like genomic data. My genome, I've had my genome sequenced. Um, as much as we all don't like to think about it, there will be a day when I'm not around, and my son, for example, will be the legal steward of my medical data. Um, I do believe he should have the rights to kind of have to do it for whatever he needs it for, personal, medical, or otherwise. Um, but at the same time, I really don't want him to kind of be able to kind of share my data and then kind of lose control of it. I want him to kind of use it for the purposes that it might be needed also. And so the challenge that they have is more like the informatic, kind of legacy that we might all have is or is legacy of specific studies or specific individuals, that whoever has legal rights to control that data has basically technical ability to control how that data is being used also. And so thank you. It is the kind of a very kind of knotted up question about the use of data and data rights and data control at its heart also.
Thank you.
Yep.
So, Winfred Wu, you have the floor.
Oh, thanks. Thanks, Dr. Rohloff. This is a really interesting talk. Just a question with respect to, doing analyses on encrypted data. So the results you had presented earlier were really interesting. I'm curious to hear what has there been work on kind of doing similar analyses? I'm assuming the data that was presented was maybe more kind of in the discrete structured data domain, but I'm curious, has there been analysis on, kind of working with more unstructured data and kind of, what findings there have been with respect to, doing analysis, with that type of data while, still encrypted?
Right. No, that's a great question, and I'm going to answer it a few different ways. You're right that most of the things that I've shared before have been a bit, so to speak, well-structured data. So things like imagery data, things like BCF files, things like that are highly structured. And inherently, compute in general, not just encrypted compute, is going to be easier, cleaner, more efficient the more structured data is, and there's kind of no getting around that. We as a community have been moving to increasingly integration with less structured and semi-structured and unstructured data. And it is a bit of a road that we are on. And so, for example, if you were to ask me, can we just take, clinician notes, handwritten clinician notes and do something with it? Well, the answer to that is frankly, well, nearly not much. There's no black magic here. If you can't do something in the clear, you're not going to be able to do it under the kind of the cloak of privacy at the same time also. That being said, although I don't have necessarily case studies to point to in the medical domain, we have been moving efficiently in the semi-structured and less structured spaces in support of financial crime fighting, fraud detection, and whatnot, and financial services, about how we could take things like, addresses, names, misspellings, transliterations, and things like that, and start doing processing of this kind of less structured data as it is too. So the answer is yes, some, and to a point, and it is a very hot topic of research for us, kind of as not only as domain, but also the team I'm involved with in general too. But it's a very good question, and thank you.
I agree. Excellent question. So with our remaining minute, I'd love if you could see the third question in the chat, if you could.
Sure.
Thanks.
Yeah, so Mr. or Mrs. Anonymous, whoever you are, thank you very much. The question is, do these systems have the ability to check and do data cleaning before any formal statistical analysis? And so basically data is messy. You know, sometimes there's missing data elements. Sometimes there's mislabeled data elements. Do they have the ability to do this? And so the short answer is yes, as long as that there is a set of rules to follow, you know, things like a code book and things like that, there is the ability to do data cleaning up to a point. If there's, for example, an intelligent human is required to do the data cleaning, well, like I said, as I said before, you can't do things under the cloak of privacy that you couldn't do in the clear. And so the short answer is you can easily automate something, then you can do it with the privacy techniques also. So thank you very much for the question. It's a very good one.
Well, I know that I've learned a lot. I think the questions from the attendees were excellent. And we are at time, so I'm sad we have to end this. But thank you again so much for joining us, for educating us. And we look forward to more learning from you in the future. Azizi, do you want to get the final word in?
No, sorry, just thank you so much, Kurt, and thanks to those folks who attended. Reach out to us as well, because I know we're gonna be, working hopefully with Kurt pretty soon, because we're trying to do something, hopefully institutional through our department. So Kurt, amazing as always, and thanks to all our attendees. And I know that maybe you may want to say this, our next speaker, which will be in February, I don't know if you want to kind of advertise that, but Kurt, thank you so much, my friend. This was amazing.
Absolutely. Yeah, so we have another series speaker coming up in February, Dr. Brendan O'Leary, and we're very excited to talk with him. He's going to do more of sort of a fireside chat with us on the role of AI and the history of AI in healthcare and medicine. So that please be on the lookout for those announcements. We'll be advertising that starting this week. So thanks.
Yeah, no, Marita, I love that. Just to a huge shout out to you and for the work that you and the team has done to secure great speakers like Kurt and I know Brendan. Brendan used to actually lead the Center for Digital Health at the FDA. So we're really heavy hitters that we're getting. So thank you so much, Marita and LaRonda and Jasmine and the entire team. And thanks again, Kurt. We'll be reaching out to you soon.
Enjoy the rest of your day, everyone. Thank you so much.
Thank you. Have a great day.